Hello, everyone, and welcome to the third webinar of the APDA Connecticut Chapter Educational Webinar Series. My name is Holly Seymour, and I am the Program Director of the American Parkinson's Disease Association Connecticut Chapter. Thank you so much for joining us. We are extremely grateful to Dr. Duarte Machado for volunteering his time to present the topic of deep brain stimulation. Is it right for me? After some brief announcements, Dr. Machado will give his presentation, and then we will be answering your questions in a Q&A session. American Parkinson's Disease Association Connecticut Chapter, or APDA-CT for short, is part of the largest grassroots network dedicated to fighting Parkinson's disease and works tirelessly to assist more than 1 million people with Parkinson's disease in the United States live life to the fullest. In the state of Connecticut, there are approximately 12,000 people living with Parkinson's. The APDA Connecticut chapter offers a variety of services in the state of Connecticut. Please visit our website to explore all that we have to offer. Our website also hosts a vast array of publications, webinars, articles, and information that can help you understand Parkinson's disease. If you are participating from another state, we have chapters and locations throughout the United States, and you can find that contact information on our website as well. APDA Connecticut is available through our helpline, email, as well as via our social media outlets. We want to thank our sponsor, Medtronic, one of the DBS providers, and we'll learn more about that. And now to begin our presentation, we are delighted to welcome Dr. Duarte Machado. Our guest today is a board-certified neurologist with subspecialty training in movement disorders. He committed to a career caring for those with movement disorders while a student at Crosby when his grandmother was diagnosed with Parkinson's disease. He is a 2001 graduate of Trinity College with a BA in neuroscience. He's a 2005 graduate of the University of Connecticut School of Medicine. He completed neurology residency training at Yale School of Medicine, where he also was chosen to be chief resident. Dr. Machado was subsequently recruited to join the faculty at Yale, where his primary responsibility was the care of patients with involuntary movements in the neurology outpatient clinic in the Division of Movement Disorders. Dr. Machado is currently Director of Program Excellence and Recognition at the Hartford Healthcare Ayer Neuroscience Institute's Chase Family Movement Disorder Center in Cheshire. Dr. Machado has participated in numerous clinical research projects. He has been heavily involved in the teaching of medical students, residents, and fellows, and he completed the Medical Education Fellowship Program at Yale. And may I add, a wonderful friend to APDA, so we are thankful for his participation today. We are excited to have him here with us, and welcome. Thank you so much for joining us, Dr. Machado.
Thank you, Holly, for that introduction, and it's always a pleasure to...
Or...
Okay, so you are able, okay. Let's see.
Perfect.
Okay. All right. So it's displaying properly?
Yes, thank you.
All right. Yeah, so I'll be discussing deep brain stimulation for Parkinson's, and is it right for me? So the objectives are to describe deep brain stimulation as a surgical therapy for Parkinson's, review data about how effective this is for Parkinson's disease symptoms, and review some recent innovations of Medtronic with regards to deep brain stimulation. So we'll start with deep brain stimulation as a surgical therapy for Parkinson's. So we know that in early Parkinson's disease, as we take medication for it, L-DOPA, that L-DOPA provides a good on response. So it treats the classical symptoms of Parkinson's: stiffness, slowness, tremor, and patients report good effect with each dose of levodopa shown in the tablets at the bottom. In moderate Parkinson's, however, patients can begin to experience off times when symptoms reemerge towards the end of the dose and the beginning of their next dose of levodopa. And off times can also coincide with other issues like dyskinesias, for example, which are rapid, uncontrollable movements. So patients can begin to fluctuate between off time and dyskinesias with medication alone. So as Parkinson's advances, we change the dosing of levodopa to compensate for those types of symptoms. And yet, despite changing the dosing, making it more frequent or increase in dose, patients may still experience off times and dyskinesias. So when that begins to occur, then that's when we start to think about other options. Now, certainly there are a variety of options for treatment of Parkinson's disease. This slide summarizes them. There's pharmacological treatment. So aside from levodopa, there are other categories of medications shown there. There's a pump-delivered therapy, levodopa intestinal gel, that's available to also target motor fluctuations and dyskinesias. And then there's non-pharmacological treatments, including what's listed there first of deep brain stimulation. So as indicated, deep brain stimulation is effective at managing these motor fluctuations, dyskinesias, and also at times medication resistant symptoms. And I'll mention one of them specifically, and that's tremor. That patients with significant Parkinsonian tremor may not respond well to medication alone. So despite augmenting doses of levodopa and other adjunctive treatments, tremor may be resistant to medication, for which then deep brain stimulation becomes a nice option. So why DBS? So DBS, it works by reducing involuntary movements by stabilizing brain circuitry. So the brain communicates chemically, but also electrically. So the cell-to-cell communication occurs via electrical signals. And so one can think of DBS like an electrical version of dopamine. So instead of treating symptoms chemically, we could treat it electrically. The stimulation can be changed or stopped. So as symptoms change over time, we change the stimulation to match that to provide continued good symptom control. And the stimulation thus is programmable and adjustable. So really, and I'll show data on this later on, but it really provides good therapeutic control throughout a person's lifetime with Parkinson's. So DBS, FDA approved in 1997. One or two leads are implanted to deliver electrical stimulation to one of two structures, either the globus pallidus called GPI or the subthalamic nucleus STN in the brain. Now, which location is chosen depends on a person's particular symptoms. So if a person is having what's called dystonia, which is abnormal muscle contracture and posturing, such as dystonia of the foot or toes, that's bothersome, then GPI may be chosen. If someone's having significant tremor and on a highish dose of medication, then STN may be chosen. So your neurologist would help decide which location is chosen, but either one is beneficial in Parkinson's. The electrical current is delivered by a lead that's then works by delivering a current to disrupt and modulate this abnormal motor circuitry to thereby smooth out motor symptoms. So the fluctuations that a person may experience in their motor symptoms are due to fluctuations of electrical activity within the circuitry in the brain, and DBS can help to modulate that and smooth that out. And this has been provided again for several decades. In fact, the very first case of DBS for Parkinson's was 30 years ago, and it was in France, and there was just a major conference in Grenoble, France, where that was first done. That conference just wrapped up a month ago or so. So certainly there's long-term experience in DBS and with Medtronic specifically. Over 175,000 patients have received DBS across all indications worldwide. So who's a good candidate for DBS for Parkinson's? Those who have a clear diagnosis of Parkinson's, those with intact cognitive function. So all patients undergo neuropsychological testing preoperatively to ensure that cognitive function is intact generally. Lack of a significant comorbidity. So patients who have uncontrolled diabetes, for example, may not be good surgical candidates because of wound healing afterwards, for example. They may not recover from a surgical procedure. Those who have significant heart disease or on blood thinners. So there are a variety of other medical issues that may be factors with candidacy. So as long as there's not any significant medical problems, then patients would be good candidates. Those who are on medications that just haven't worked or caused intolerable side effects would be good candidates. Patients generally less than age of 80. Clear screening MRI of the brain. So what that means is that sometimes patients can develop enlarged fluid-filled cavities in the brain called ventricles, and that can then impact on the pathway or trajectory where the lead is placed. So every person undergoes a screening MRI of the brain that helps to make sure that the pathway for the lead is clear, and also to ensure that there's no other factor to account for their symptoms, since large ventricles can also cause a Parkinsonian type condition. Degree of disability. So DBS is recommended for patients who have a degree of tremor, for example, that's disabling. When it's very mild and managed with medication, then DBS wouldn't be necessary. And then also willingness and ability to be seen for follow-up visits. That's important too, because DBS is a process. And so we want to ensure that if we're placing a device, that patients will be able to be seen timely for follow-up visits in order to maximize the benefit of the DBS. Now, also good candidates, those again with tremor resistant to levodopa Parkinson's. So I've mentioned that despite increasing doses of levodopa, sometimes tremor cannot be well controlled. And so DBS is a great option for those patients. Patients who have painful off dystonia, so and particularly younger patients who have this painful muscle spasm, cramping causing posturing. DBS works well for that, again, in that part of the brain called the globus pallidus. And then those who have implications for professional life where medical treatment has been unsatisfactory. So patients who, as part of their occupation, require very fine motor skills, again, would benefit from DBS that can provide that degree of fine control of symptoms. Now, the official label for DBS for Parkinson's is bilateral stimulation, bilateral on both sides of the brain of the GPI or the STN, indicated for adjunctive therapy and reducing some of the symptoms of individuals with levodopa responsive Parkinson's of at least 4 years duration, not adequately controlled with medication, including motor complications of recent onset or motor complications of longer standing duration. And I'll show data for both of those. So this is important. So at least 4 years duration, we use that as a marker for patients. Patients who have severe tremor and have only had Parkinson's for 4 years, absolutely could be candidates. Why we get that 4-year mark is because sometimes patients present and appear to have Parkinson's, but over the first several years have other symptoms that emerge that aren't commonly seen early on in Parkinson's, like severe drops in blood pressure, for example, or severe balance problems that would indicate that perhaps they don't have standard Parkinson's disease, but rather a different Parkinsonian condition, a Parkinson plus condition, such as progressive supranuclear palsy or multiple system atrophy. So if there is the emergence of these other severe symptoms early on in the course, then those severe symptoms are not DBS responsive. So we wouldn't want to perform DBS in patients who would not fully benefit from DBS. So that's why that 4-year mark is included. So DBS is really seen in the continuum of care, that in patients who are experiencing troublesome motor symptoms not effectively controlled by medication, are in a window of opportunity to receive DBS. And so we discuss DBS for these patients who again are having symptoms not controlled with medication. Here are some examples like on time, that's characterized by disabling dyskinesias, or off time by disabling tremor, rigidity, slowness of movement, or unpredictable on-off fluctuations, or the medication-resisted tremor again. So these are all great examples of instances whereby DBS would be quite effective at helping to control these various symptoms. So I emphasize again that window of opportunity whereby symptoms are moderate to advanced. We're discussing a need to increase medication. That's when it's a good time to talk to your doctors about getting DBS. Certainly you want to do it very early on, and you don't want to wait until symptoms are severe or not well responsive to DBS, or that you're having falls, suffering from cognitive change, developing other medical problems as you age that would make you not a good candidate. So you want to discuss it when it's appropriate, that when you benefit the most from this intervention. So now let's review the data about, a little bit more about DBS and how it's performed, and then some of the data on efficacy or effectiveness. So the DBS system components are shown in this graphic, whereby there's an implanted lead. So it's either on one side or oftentimes on both sides of the brain that delivers electrical pulses to an area of the brain affecting movement. There's the extension. The extension wire connects the lead in the brain. That extension wire goes underneath the surface of the skin, down behind the ear, down the neck, to then the neurostimulator or battery that powers the system. And then from the perspective of turning the device on and then changing the parameters on it, there's a clinician programmer, something that your neurologist would use to make those adjustments. And then the patients themselves get a controller to also make some adjustments. So again, using the analogy that DBS is treating symptoms electrically instead of chemically, similar to how we would make a recommendation to a patient about adjusting the dose of levodopa if a certain dose doesn't work, we can do so with DBS. So if we send a patient home on a specific setting of DBS, a specific current, and after several weeks, they wish to make an adjustment between visits, they can do so using a patient controller. So we set parameters on that patient controller to give patients flexibility to make adjustments on their own in between visits. So the lead placement carefully planned by the surgical team. So as mentioned, all patients have an MRI generally, or a CT scan to capture images of the brain. And then the surgeon calculates the 3D coordinates and uses sophisticated software to determine precisely where the trajectory or pathway of the electrode into that part of the brain is to occur. So they call it deep brain stimulation because these structures are deep within the brain. So the middle diagram shows the globus pallidus, deep and close to the middle of the brain. And then the subthalamic nucleus in that bottom panel is even deeper and closer to the center part of the brain. So that pathway has to be very precisely planned. And so an experienced functional neurosurgeon would be able to do all of this in preparation for the procedure. So how this is done, I'll just play this video while I'm describing it, is that the electrode sends signals down to either these two structures in the brain, and the stimulation doesn't alter the brain tissue. It instead alters the electrical activity of that part of the brain that it's in. And so here we can see it modeled in 3 dimensions about where that lead is placed. So to implant that lead, the first step is implantation of the lead itself. That patients are generally admitted for overnight for monitoring, and oftentimes are discharged the following day. About 2 weeks later, that's where the extension and battery placement occurs, and that's an outpatient procedure, and patients generally go home same day. And then 2 to 4 weeks later, patients then are seen at the movement disorder specialist office to then turn the device on and do initial programming. So this delay of about 2 to 4 weeks occurs to allow time for healing before activating the therapy, reduce inflammation, and thereby we can really get a good sense of how they're doing. Certainly, soon after the device is placed, some patients have what's called a lesional effect, meaning they see some benefit even before the device is turned on. And so we give it some time for the patients to reach steady state again, and then they come in, off medication, we turn the device on, and we go from there. So that process is programming. So programming the DBS, stimulations turn on for the first time, improvements of symptoms are often immediate, especially with tremor. It's really remarkable to be witness to seeing tremor just gradually diminish and then disappear. Tremor that has been refractory to medications, for it to resolve with a single session of DBS is truly a remarkable thing to witness. And nothing else can suppress tremor as well as DBS. So this programming process is customized to patients. So depending on their particular profile, we determine which stimulation parameters to choose, and then do so to also minimize side effects. As with any surgical procedure, there are risks to DBS. So there's surgical risks, device-related complications. These are quite rare, depending on the center that's done. Each individual center has their own outcome data, but generally less than 1% of bleeding or stroke, seizure, infection. And with regards to interference with other medical devices, certainly some patients have a cardiac pacemaker already. So if that's the case, then on the left side of the body, then certainly the surgeon would be placing the DBS implantable pulse generator, the battery, on the right side of the body with a certain distance away. So certainly patients can and do have both types of battery systems. DBS, I've mentioned, reduces tremor. So it's the most effective anti-tremor technology available. It improves disability, improves activities of daily living, and is reversible. So I'm going to show data about how it does all these things, and what the data shows with regards to tremor reduction, disability, and activities of daily living. Now, symptoms that don't respond well to DBS are the following: speech dysfunction, swallowing problems, slow, soft speech, small handwriting called micrographia, postural instability, whereby there's a change in a person's posture. They may lean too forward or may fall backwards easily. That tends not to improve with DBS. And then freezing of gait will not respond well to DBS either. So patients are informed of what will and will not respond to DBS, so that we have good expectations going into procedure about what we're looking for to improve as we're going through that process of optimizing their programming. Now, how much benefit is there? There have been studies looking at DBS therapy plus best medical therapy combined versus those patients who just have best medical therapy on its own, and they look at, for example, how much on time can a person experience without troublesome dyskinesia, and those who combine DBS with best medical therapy have an additional 5.1 hours of good on time without troublesome dyskinesias. That is in part due to the fact that medication is reduced and after DBS, and so by reducing medications, that helps reduce dyskinesia, because dyskinesia is a levodopa-induced phenomenon. All of these other symptoms, as mentioned, tremors, dyskinesia, rigidity, bradykinesia, they'll also improve with DBS. Now, patients ask, well, what's some of the, understand that these issues in the short term can improve. How about, some of my longer term problems? And the data on this is also clear that in the dark blue is DBS plus best medical therapy. The lighter blue is best medical therapy alone, so oral medications alone. And when it comes to all these parameters, so in the short term, when we look at disease-related quality of life, their motor skills, activities of daily living, dyskinesias, good on time, the percentages are all much higher in that navy blue color, that dark blue color, when it comes to combining DBS in a person's treatment regimen. And the same goes for longer standing motor complications. So even for patients who've had motor complications for years, those will also improve after getting DBS. The one thing that drops down is the change in daily levodopa equivalent dosing. So patients who get DBS for both short and long-term issues are able to reduce their medication burden. And how long does this last for? DBS shows robust symptom improvement over the long term as well. So here looked at data in the first year, third year, and then fifth year after getting DBS. And across the board, symptom improvement is seen. Again, greatest for tremor, but certainly rigidity improves significantly as well. And then to a lesser degree, but still significantly, is akinesia. And so patients can expect to continue to experience good relief of symptoms over time. So as Parkinson's progresses, we know that these issues would get worse, and yet we're still able to adjust the DBS to continue to receive good improvement of these motor symptoms. So now if we compare again, medication alone versus adding on DBS. So I showed you how in the study, if you stay on medication alone, you don't gain any additional on time if you're on your best medical regimen already. But if you add DBS, you'll gain 5.1 hours of additional on time without troublesome dyskinesia. Medication alone can be unpredictable at times. And this is related to another point later on in this graph about GI absorption. So the medications are dependent on being absorbed through the GI tract. And so if there is constipation, if there's inflammation in the gut, a variety of issues can result in the medication not being absorbed reliably, and that will lead to unpredictable motor response. Whereas DBS, it's more predictable. It's directed to the site where the motor circuitry is located, and it doesn't require GI absorption, and so that leads to a much more predictable response over time. It's delivered continuously instead of what's called pulsatile, so taking oral medications at discrete time points can result in this up and down type of motor symptom control, whereas with DBS, it's continuously delivered. And it provides an easier way to go about your day because your medication regimen is simplified as well. And so that would diminish also some dosing compliance challenges that we often see with those who remain on medications alone, where we're increasing, for example, levodopa from 3 to 4 to 5 times per day. finding times to take levodopa when you're not eating and when you're not doing some other activity might be challenging. And so for using DBS and having a more simplified medication regimen, then that certainly is of value. So the summary for this portion of the talk is that, DBS is certainly not a cure, but as as disease progression continues, we can modify DBS accordingly. We set realistic expectations for symptoms that we know should improve versus those we know likely will not. It improves quality of life, improves motor symptoms. Patients have less off time, better on time, less fluctuations, and overall allows for medication reduction. So now the last section is to discuss Medtronic DBS innovations for Parkinson's. So Medtronic was the first device company that produced deep brain stimulation. Since then, in recent years, there have been two others, Abbott and Boston Scientific. Medtronic fairly recently developed the Percept device. This is a new type of battery that delivers controlled stimulation similar to a cardiac pacemaker, but it allows for a greater ease of programming, which I'll get to in a moment. So aside from this advanced battery, there are also advancements with the leads themselves. So now there are Sensite directional leads. So these are small wires placed in the brain that are segmented. So they allow for us to fine tune where the stimulation is going within that very small part of the brain. And here's a picture of the DBS programmer, the patient programmer, where you can check the battery status, turn the device on and off, and allow for one to record certain events, like if you're having tremor and you want to record when that tremor is occurring in the course of the day, then the device allows you to record that and allows you to change the current or some other parameters as mentioned. So why you'd want to turn your therapy on or off is, for example, if you're going to have a specific procedure that can cause that for which some interference may be seen with the device. A common example is getting an EKG, for example, of your heart. You'd want to turn the device off so there's not interference between the stimulation from the device and the electrical signal that's being picked up from the heart on the EKG. The Percept battery, it's smaller and thinner compared to their prior battery, designed to facilitate expanded capabilities with software upgrades that I'll show you in a minute. And it has better longevity also compared to the previous model. Now, on May 25th, 2021, the FDA approved the Sensite directional lead system. So as mentioned, the lead has segments on it. There's 4 different contact points, and then 2 of those contact points are divided into 3 segments. And this allows one to steer the current more precisely. So instead of getting a ring of stimulation around the lead, one can change the shape of the current to direct the current to a particular part within that structure, because these structures, as I showed you earlier, are very small. And so when the structure is that small, we want to minimize side effects by keeping the stimulation precisely in the structure of interest and not have it expand outside of that. So having these directional leads allows for greater capability in the programming. Now, the Percept device battery allows one to then not only deliver electrical impulses into the brain current, but also actually sense what's happening in the brain. So it's called brain sense technology. So it's the first complete DBS system that allows for sensing capabilities. So when, for example, when I'm programming a patient for the first time, I can actually do a brain sense survey, which gives me an understanding of what the innate brain signals are, and along the electrode, where is that brain signal the greatest? So if I want to try to suppress that signal, it's called a beta band signal. Then I identify, where that signal is greatest, that signal that's causing the tremor. I then introduce a current at that contact point, shown here as contact point number 1B in this blue zone. I introduce a current. The current is shown here on this physician tablet, shown at 2.3 milliamps of current. I can increase the current at that contact point, and I can see the beta signal diminish. So as I increase the current, the innate brain signal diminishes, and then I'm looking at the patient before me, and I can see that their tremor is diminishing as well. So everything's occurring in real time, right? I'm actually seeing the correlation between diminishing tremor signal in the brain, and then the tremor diminishing in real time on that person. So this allows really for a much more complete picture of what's happening within the brain, and allows for us to really fine tune the parameters on the stimulation to achieve optimization of stimulation much sooner. So we can achieve optimization within sometimes as quick as a single visit, but more often 2 to 3 visits. And by then, the parameters are optimized and symptom control is achieved. Now, once we get to that point, then patients would then come in for standard office visits, and we can further fine tune from there. But with regards to then living with DBS, some of the common questions that arise are, will I be able to resume activities? And certainly, resuming many activities are possible. We just discussed, soon after having the battery placed in the chest, not to do any activities that would put stress on the chest muscles, like boxing, for example, holding off on that until the site heals fully. Another question is travel. Yes, Medtronic provides a device identification card, and so you're absolutely able to travel with this. Getting an MRI is also possible. The Percept PC is the first DBS system with 3T MR conditional capabilities. So 3T is a more powerful MRI. The less powerful is a 1.5 Tesla magnet, but the 3T Tesla magnet really provides excellent anatomical detail. So if that's needed for patients to have done in any body part, then that can be done. And can I check my DBS battery? Certainly, I've already mentioned that. Using a cell phone type device that your patient programmer will allow you to conveniently check your battery and make adjustments really anytime. So all of these are in place to make it as smooth and seamless transition as possible to receiving DBS. So a summary of DBS is that this provides directional stimulation and sensing capabilities to deliver precise, targeted therapy to your stimulation needs. So whatever your symptoms happen to be, we can target that very precisely and fine-tune the degree of stimulation that you need to suppress the tremor to the extent that's necessary. The Percept employs BrainSense smart technology that continuously captures and records brain signals to optimize stimulation. So even in between visits, if patients want to use their handheld device to record when they're having tremor, for example, when they come back into the clinic, I can then review that log and see at what points they're still having some breakthrough symptoms, and then modify the device even further. So that brain sensing occurs not only in the clinic where I can see it in real time, but that could be occurring throughout in between visits to get some additional data. So really through all of these innovations, it's led to a product that is really innovative and provides an overall good experience for patients with suppression or reduction of symptoms as much as possible. So when is it right to consider DBS? So if you have Parkinson's, you may be eligible for DBS if you meet criteria or medications haven't worked or have caused intolerable side effects, and the tremor is disabling, keeping you from doing what you want to do. So in summary, DBS patients may experience a number of benefits or tremor reduction. I can't emphasize this enough, that tremor reduction, 70% or greater, nothing works better than DBS when it comes to suppressing tremor. There's no medication that can deliver the results with regards to tremor suppression that DBS can. It can provide more on time to increase a person's overall fluidity of movement, so they're not having off times where they're feeling stiff and slow. It allows for medication reduction, so decreased pill burden, ease of dosing, less medication side effects, the list goes on, and also then improved quality of life. So improvements in quality of life metrics are frequently reported by DBS patients. At our center, we capture this data, and so we have our own data about the degree of quality of life improvements that our patients have experienced. All right, so at this time, I'm happy to now take any questions, or if you want to type in any questions in the chat, I'm happy to answer those.
Thank you, Dr. Machado, for this very informative presentation. We do have a couple questions already in the Q&A box, so I'll read those. Dr. Machado, can you comment on how DBS will influence visual coordination, especially for those individuals wanting to drive?
Yeah, so yeah, this is it's important to understand, is there a pre-existing? So I'm trying to get a sense from the question is, if the person had some pre-existing visual problems, then those are likely to persist. So DBS is not going to improve that issue per se, even though having visual coordination problems is very common in Parkinson's, unfortunately, because the eyes move by a series of small movements by very small muscles that can turn the eye in multiple directions and rotate the eye as well. And so because those extraocular muscles are muscles, they are also impacted by Parkinson's. But DBS, may not improve that problem for those who have that problem pre-existing. For patients who are experiencing that, we do send them to an ophthalmologist or neuro-ophthalmologist to get very precise mapping of their visual fields and understanding of their visual coordination problems. And then we can send them for a repeat analysis after DBS to see if there's been any change, but oftentimes there's not.
Thank you. Thank you. That's very helpful. I personally have met some different people at support groups, and when DBS is brought up, some people are not aware of it, and they're curious as to why their movement disorder specialist or neurologist hasn't brought it up to them when they hear about the great symptom management that it can provide. Can you give us any tips or feedback about why a specialist may not be talking about it, or how to bring up that to your provider?
Yeah, I mean, it's an interesting dilemma, because we know that DBS is grossly underutilized nationally and internationally. that there's data that's been collected that in the US, perhaps only up to 12 to 15% of patients with Parkinson's are getting or being considered for DBS, and certainly the numbers should be much higher when we consider how many people have, tremor predominant Parkinson's. But the issue is complicated because some patients with Parkinson's, tremor is not their main symptom, so DBS wouldn't be discussed for those patients. And then I think it's a sense that we can try modifying or adjusting medications visit after visit after visit, and over time a lot of time is lost in that process, and instead if we can get to the point of discussing DBS sooner, as I mentioned, as early as 4 years in those with tremor predominant Parkinson's, then that should be done. In Connecticut, we have the fortune of having ample number of movement disorder specialists. So it may be less of a case in Connecticut, even compared to other parts of the country, where access to a movement disorder specialist is even harder to come by. But there is absolutely room for improvement for all of us to be discussing DBS more often, because there are patients who would qualify, but they're just not getting the information just yet. So hopefully with continued innovation and continued discussion about DBS, and as I mentioned, this large conference in Grenoble, France, really help to rejuvenate the field even more. I would think that the number of people getting DBS in the future will continue to increase.
That's great news. Thank you. There was a question about DBS. Will it help those with a freezing gait?
Yeah, so freezing gait, very complicated. There's been research on use of DBS for freezing gait, but using other structures. So there's something called a PPN. It's a different structure deep within the brain, a different target, with the thought that if we target the PPN, that perhaps that can help with gait. So there were some clinical trials done where that was evaluated, but the results were not convincing enough to then pursue. So as of now, we tell patients that DBS typically doesn't help with freezing gait. Instead, we look at modifications of levodopa. So plus really specific physical therapy. So for my own patients who are experiencing freezing gait as their main symptom, then we look at Duopa, which is a continuous levodopa infusion that can help with freezing gait. I have some patients where they've had DBS for some time, but as their Parkinson's progresses, maybe now the other symptoms are well controlled, the ones I mentioned, tremor, stiffness, slowness, but freezing gait is their main issue. I'll combine it with Duopa, so the two can be used concurrently. So again, for severe freezing gait, we're looking at optimizing levodopa to help overcome that issue, and you can combine both types of procedures to get best outcome.
Well, thank you. Give it just another minute to see if anybody has any additional questions. Just to circle back, what is the best way to bring up DBS to your doctor at your appointment? Just come out and ask about it, ask if you'd be a good candidate for it. I know there can be some rigorous testing that you have to go through to be sure that it is appropriate. So how do you suggest making sure you're getting in that window of opportunity?
Yes. Yeah, so the key here are, if you've had Parkinson's for 4 years or more, and you're on a medication regimen that's not providing sufficient symptom control, when you go to your doctor and you mention, I'm still having, bothersome tremor, and if your doctor is to say, well, we can make this medication change, that's when you can say, are there other options other than changing medication? I've heard that there's a surgical option that could be of help. So that could be the lead in to open the door into that discussion on DBS. But that's the key. Having bothersome symptoms, in particular tremor, that aren't sufficiently controlled with medication.
And then just a follow-up kind of question about the freezing gait from the same person. Who should they see about their freezing gait?
Yeah, so we, for example, at our center, we partner very closely with dedicated rehab team. So your neurologist should likely have you see a physical therapist who is skilled at specific techniques to overcome freezing gait. And there are absolutely techniques in that regard. There are even some devices that have been shown to help. So for those, for example, that use a cane, there is a cane, the laser cane, that then projects a beam of light onto the ground to provide a visual cue to overstep that beam, and that can overcome some freezing. Similarly, there are walkers that project a beam. Some walkers, like the U-step walker, also uses a sound. There's a button that can be pressed on the walker that produces a particular beat that allows a different type of now auditory cue to help overcome freezing. So there are things that could be employed that a physical therapist skilled in this area would be able to help. So between your movement disorder specialist or neurologist plus a skilled physical therapist, that's the best way to overcome freezing of gait.
Thank you. Thank you very much for that. All right. Well, that concludes our Q&A session. So I'll just go back to my presentation. All right. And, for additional information, questions, resources, please visit our website, apdaparkinson.org/CT. My email and phone number is there. We have a wonderful upcoming educational series about Parkinson's disease and gut health, and that is presented by a registered dietitian from RVNA Health, Monica Marcello. So that should be wonderful next month. If you enjoyed today's webinar, we hope you will consider supporting APDA Connecticut with a donation. With your help, APDA Connecticut can deliver more programs and services like this one, which are needed, to support the community. And save the date for our Westport, Connecticut Optimism Walk on September 30th. Hopefully Dr. Machado will be joining us there. And certainly it's a beautiful location at Sherwood Island State Park, and a really wonderful event. And thank you again for joining us, and to our sponsor Medtronic for this program. Oh, and there's an additional question that just came through. So I'll see if Dr. Machado can answer. Can emissions damage device?
Like emissions in the ear, I'm like from equipment, I'm assuming. Yeah, not to my knowledge. It'd have to be something. So anything that, in terms of damaging the device, would be something that for which there's physical contact. I mean, it's not something I've seen except for one case in my career where there's been some, physical damage. Electrical emissions. Those would have to be extraordinarily powerful. So in day-to-day, working. So when DBS was first developed, there was thought, oh, if you're getting too close to even some household devices like microwave, could that damage? And really the answer is no. It'd have to be something that produces an extraordinarily high amounts of electrical emission for it to cause any damage. So that would be more occupational related, in which case for individuals who have a specific occupation that would put them in a situation where there's high electrical emissions, then that would be a case-by-case basis to then discuss with the employer and then the neurologist and to discuss whether there's any potential for harm there, but not on a regular, everyday living situation.
And I'm sure whoever the movement disorder specialist who's working on the programming could certainly look at the occupation and the exposure.
Right.
Absolutely. All right. Well, thank you. Thank you, everybody. If you know someone who missed today's program, or if you joined late, or if you'd simply like to watch again and be dazzled by Dr. Machado's program, we will be placing this on our recorded program section of our website in the next day or two. So I hope you all have a wonderful afternoon. On behalf of the entire APDA Connecticut chapter, many thanks to Dr. Duarte Machado and all of you for participating in today's program.
Thanks so much.
Thank you. Have a wonderful day.